Good evening, everybody. Thank you, Bindu, for having me over. I'm going to take you across a very simplified talk for controlled ovarian stimulation for IVF in endometriosis. So can you hear my voice?
Yes, ma'am.
And you can see my slides?
Yes, ma'am.
Sorry. Yeah. So I hope my slide moves. Okay. Why does one have to think differently for ovarian stimulation for women undergoing IVF with endometriosis? This is my first question. Why have you brought this topic for me to speak? Well, it is because these women have mostly low ovarian reserve. One is due to ovarian disease and the other one is due to surgeries. And because it is the disease of the ovary where the oocytes are produced, so a lot of time we have poor oocyte quality, which results in a poor embryo quality. And along with that, with the endometrioma sitting somewhere in the pelvis, endometriosis all over, the endometrial receptivity gets impaired. What happens? Lower expression of HOXA 10 and alpha 5 beta 3 integrins happens. So when you remove endometrioma, you also increase the endometrial receptivity by bringing back the expression of these two integrins and HOXA 10. Or there could be associated adenomyosis, which is the brother of endometriosis. So this causes altered receptivity of the uterus also. I mean, in the uterus, due to changes in the uterine musculature and blood supply. What does one need to consider to develop an ideal protocol for IVF in endometriosis? Well, we all understand, like in all indications, age of the woman is very important, her ovarian reserve, her duration of infertility, and most important for a woman who has endometriosis to see what stage of endometriosis she has. Now, what is the aim of an ideal protocol? Like in natural cycle, the LH surge happens and ovulation happens. Here, we have to block the LH surge so that we can make multiple follicles and then at the end, give a trigger with either HCG or release the LH surge so that we can have all the eggs matured, which we can aspirate on the day of oocyte retrieval. So what is our aim? Good number of high quality oocytes. One is very important because if we have good quality and a high number of oocytes, we'll make good embryos. And another important thing is best endometrium for implantation. So it is that we need to take care of the seed as well as the soil. Now, why do we need pre-treatment before controlled ovarian stimulation? Sonia told us that you can give it before ART for IVF in these patients with endometriomas. The reason and why do we need it and when do we need this? This is because endometriosis is an inflammatory condition, which we've just heard in great details. And any presence of inflammation in the pelvis would reduce the chances of pregnancy by acting on the quality of oocytes, by acting on the integrins of the endometrium. So we will, by sort of suppressing the integrin expression of the endometrium, so we need to remove as much as endometrioma or endometriosis we can. So what are the pre-treatment? Well, it could be surgical and it could be medical. Now, we've been very nicely told that there's very little role left for surgical pre-treatment except in special circumstances. Which are they? If it is a large endometrioma, larger than 4 centimeters in diameter. This is not the volume, this is the diameter. And she's had no previous surgery, then it is best to probably operate it. Or if we have the diagnosis of endometrioma in doubt, we think it could be a tumor condition for the ovary, or there are large hydrosalpinx also, and that also bilateral hydrosalpinx, then it is good to go in with a laparoscope into the patient. And when you do ultrasound, you find that all the follicles or ovarian cortex is distal to the cyst from the vaginal wall and probe. So you put in a probe and you find the whole cyst sitting against the vaginal wall, and the cortex, as well as all the follicles distal to it. What will happen when you push in the probe? You will first enter the cyst, and then you will be able to reach the follicles. In these cases, and if she's a young girl and has a good ovarian reserve, then also we can think of removing her endometrioma, downstaging her endometriosis, give her a chance for natural conception, which if doesn't work, we have enough time, we have enough reserve to go in for IVF. What is the medical treatment? When do we prefer medical treatment? One is she's already had a previous surgery or surgeries for endometriosis. We would never want to again go for another surgery, even if the endometrioma is big, because the diagnosis has been established in the previous surgery. First time endometriomas, less than 4 centimeter, medical pre-treatment is so much better. Compromised ovarian reserve, well, only medical treatment. And advanced stage, again, only medical treatment. So you know that when would you want to give a medical treatment? All these conditions. Surgical treatment only when your diagnosis is in doubt, large endometrioma, or you just can't reach the follicles, or a very young woman with a good reserve. So what are the two protocols which are the popular protocols for ovarian stimulation for IVF? This is not for endometriosis, this is for any IVF. Either it is the antagonist protocol or it is the long agonist protocol. So these two, what do? They suppress the LH surge so that a lot of follicular cohort can grow up to dominance, and then we can aspirate oocytes from all these follicles. So apart from this, which is the ideal protocol for endometriosis women? Is it long GnRH-agonist protocol or the GnRH-antagonist protocol? Well, long GnRH-agonist versus short GnRH-antagonist in endometriosis has been studied time and time again, and both have similar IVF outcomes. If we can make a good cohort while using a GnRH-antagonist, and if we do suppression by long GnRH-agonist, when I say long GnRH-agonist, it means we've started GnRH-agonist on day 21 of the previous cycle luteal phase, so that we've been able to suppress all the little shootouts of the follicular cohort, which happens by pulses of FSH-LH coming from the pituitary. And there is an even cohort when we start gonadotropins on menstruation. Why? Because actual impact of GnRH analogs, which include both agonist and antagonist, is on ovarian hormonal control, not on oocyte and embryo quality. So when we use antagonist or we use long agonist protocol, we are only controlling LH surge of the ovary during the COS or controlled ovarian stimulation cycle. It doesn't change the oocyte and embryo quality. What will change the oocyte and embryo quality or endometrium? If we can reduce the inflammation which is produced by endometriosis. And what happens in endometriosis? There is so much of inflammatory secretions in the pelvis, in the ovary. There is macrophage recruitment and activation because of all these changes. The first thing is retrograde menstruation happens, intracellular adhesion molecules are produced, fibronectin is produced, and these endometrial glands, which go with the menstruation into the pelvis, these endometrial fragments start getting adherent to the peritoneal surface, to the ovarian surface, to the two uterosacral ligaments. Now, once they get adherent, what is produced? The biggest enemy, that is vascular endothelial growth factor and interleukin-1. The moment they are produced, vascular endothelial growth factor immediately neovascularizes all these implants. Now, once they are neovascularized, what happens? They'll start proliferation, and under the effect of estradiol, they will proliferate and further produce more estradiol. And along with that, they'll produce IL-6, then the surface adhesion molecule 1, and all this in turn inhibits the NK cells, proliferates the B and T cells. What happens? All the pro-inflammatory action starts. There is endometrial dysfunction due to the integrin suppression and HOXA10 suppression. The embryo is affected because of the oocyte having some inflammatory changes within the ovary. And even the sperm which passes through this environment may go through changes due to pro-inflammatory factors, a lot of macrophages present, which cannot be cleared out by, the inflammation which cannot be cleared out of the woman's pelvis. And this leads to impaired fecundity and subfertility. So first thing came in the novel mechanism of action of prolonged use of GnRH agonist in endometriosis. We all understand you give prolonged GnRH agonist, a depot preparation for 3 months, 6 months. What does it do? It will suppress ovulation. It will reduce exposure of endometriotic implants to a growth factor, which is known as midkine in follicular fluid involved in proliferation of endometriotic cells. So if there is no follicle which grows into ovulation, then the growth factor also will not be there. It will also directly inhibit proliferation of endometriotic cells by regulation of apoptotic and angiogenic mechanism. So it is anti-angiogenic. It also inhibits menstruation in a lot of patients. Most of these drugs do, or they reduce the menstrual flow, which reduces exposure to thrombin and its protease-activated receptor factor, which leads to cell inflammation. So menstruation stops, the cell inflammation stops. Inhibition of endometriotic cells proliferation stops, and inhibition of uterine contractions. It blocks mechanical stress also. So having said that, ultra-long protocol was said to be ideal for endometriosis in 2006 by the Cochrane Database Systematic Review. And this was a presentation by Salim et al., where he considered 3 RCTs, which had 165 women. And they said live birth rate goes up by 9 times and clinical pregnancy rate is higher by 4 times. But then this was refuted in 2019 by the same Cochrane Database Systematic Review by different authors, which has Giorgio, Mello, Baker. And Salim again was in this sort of committee also. And what did they say? Endometriosis is known to have an impact on fertility, and it is common for women affected by endometriosis to require fertility treatments, including IVF, to improve the chance of pregnancy. It has been postulated that long-term gonadotropin-releasing hormone agonist therapy for 3 to 6 months prior to IVF or ICSI can improve pregnancy outcome. But this systematic review supersedes the previous Cochrane review on this topic. And what does it say? Contrary to the previous findings, we are uncertain as to whether long-term GnRH agonist therapy impacts on live birth rate, which earlier was said 9 times higher, and pregnancy rates were 4 times higher, and whether it even has an effect on complication rate compared to standard IVF ICSI, where no downregulation is done. And because we have very little data and very low quality existing data, particularly for the primary outcomes examined, further high quality trials are required to definitively determine the impact of long-term GnRH agonist therapy on IVF ICSI outcomes in women with endometriosis. So gone is the long-term GnRH agonist therapy. Yes, you can give it for suppression of endometriosis, reduction in size of endometrioma, but to have said that it will increase the live birth rate is now a big question. Now, this is the effectiveness of different down-regulating protocols on in vitro fertilization, embryo transfer, and endometriosis, a meta-analysis. What did they do? They looked at GnRH ultra-long protocol, which is for 3 to 6 months, a normal GnRH long protocol, which is for 21 days, just starts in the luteal phase of the previous cycle. And they also looked at GnRH agonist short protocol. So they used only agonist in this, ultra-long, long, and short protocol. What did they find? Subjects of study were women diagnosed with endometriosis by either laparoscopy, laparotomy, or transvaginal aspiration of ovarian endometrial cyst combined with the histopathology. And they found that GnRH agonist ultra-long protocol could improve the clinical pregnancy rate. This came in after the Cochrane review came. So they said that it could improve the clinical pregnancy rate of infertile patients when RCTs were conducted, especially in patients who have advanced stage endometriosis. That means if there is advanced stage endometriosis, we could think that some improvement will happen if we give an ultra-long protocol for 3 to 6 months. But then a subgroup analysis was done, and they found that different down-regulation protocols provided no significant difference in improving clinical outcomes in patients with endometriosis, especially in the non-RCT studies, which were non-RCT, they were just given as such. What are the limitations of prolonged downregulation? We used to think that let us give downregulation for 2 months. No, it's not enough. 3 months. No, it's not enough. 3 to 6 months is what's recommended. So what was the limitation? One is it's time consuming. I mean, 3 months just go, patient has come to you, wants a pregnancy right now. And there could be diminished response, especially in poor responders where we've done a long-term suppression. So came in the newer therapy, medical methods to minimize negative effect of endometriosis on oocytes. Now, these medical methods are pre-treatment with OCPs for 6 to 8 weeks. So it's a short treatment, 6 to 8 weeks. Or letrozole is added with GnRH-agonist for 8 weeks. I'm sorry about the sound. There is a lot of sound in my room. I'm so sorry about it. Letrozole with GnRH-agonist only for 8 weeks. So we've minimized that 6 months duration or 4 months duration to 6 to 8 weeks. Or Dynogest pre-treatment for 3 months. So these came in the oral treatment as pre-treatment before inducing ovulation, where we would do controlled ovarian stimulation by either the agonist long protocol or the antagonist protocol, which we normally use, the 2 protocols. Now, I have brought in 3 studies only to see what happens. Continuous oral contraceptive versus long-term pituitary desensitization prior to IVF ICSI in moderate to severe endometriosis study protocol of a non-inferiority randomized controlled trial. Now, this is still underway. It was proposed in 2019. It was formulated and the whole methodology was shown in human reproduction. And what is known already? What did they say? That we all know that long-term pituitary desensitization with a GnRH-agonist for 3 to 6 months prior to IVF ICSI improves clinical pregnancy rates and in women suffering from endometriosis, even though it reduces the response. Alternatively, IVF ICSI pre-treatment with continuously administered oral contraceptives may offer fewer side effects and lower indirect cost, as well as encouraging IVF outcomes in women with endometriosis. To date, these 2 different IVF ICSI pre-treatment strategies in women with endometriosis have not been directly compared. So what they propose to do, a 2-arm study. On one arm, they would give GnRH agonist long depot preparation for however many months. And on the other arm, they would give just OCP continuous, where no menstruation, no ovulation would happen. And this was an open label parallel 2-arm randomized control multi-center trial has been planned. It is still underway. I searched for the results yesterday and it's still underway, including patients with moderate to severe endometriosis. Sample size calculation is rounded off to 165 patients per group. So 330 to 340 patients in total will be included. After informed consent, web-based block randomization will be stratified per center. And we expect this study inclusion is expected to be complete in 3 to 5 years. So by 2024, we should get the results of this study. So this is one plan where a OCP has been planned to be given continuously. Another is comparison of a 2-month pre-treatment with GnRH-agonist with or without an aromatase inhibitor in women with ultrasound diagnosed ovarian endometriomas undergoing IVF. So what happens here, instead of giving a depot preparation of GnRH-agonist alone for 3 to 6 months, just 2 months of depot GnRH-agonist. On one arm, they give only GnRH-agonist. On the other arm, they add an aromatase inhibitor in women. And who are these women? They have been diagnosed by ultrasound and they are undergoing IVF. So what was their research question? Does the addition of an aromatase inhibitor improve IVF outcome in women with endometriomas when pre-treating them with gonadotropin-releasing hormone agonist depot preparations? Well, the design of this was retrospective 2-center cohort study involving 126 women aged 21 to 39 years who failed a previous IVF cycle and all subsequent embryo transfers and had sonographic evidence of endometriomas. So they made sure that one IVF cycle had failed. These were all women who were less than 40. They were non-randomly assigned to either 3.75 milligram intramuscular depot leuprolide treatment alone every month or in combination with 5 milligram of oral letrozole daily for 60 days prior to undergoing a fresh IVF cycle. Main outcome measures included clinical pregnancy rate and ongoing pregnancy rate after 24 weeks of gestation. The conclusion was the combination of dipoleuprolide acetate monthly for 60 days combined with daily letrozole has better clinical outcomes at IVF in women with endometriomas than dipoleuprolide alone. So what we want to say that 60 days, just depot preparations are not enough. 2 months, 3 months, they are not enough. We need to go up to 4 months or maybe even more. But if we can combine something which will further reduce the estrogen exposure to these endometriotic implants, something like aromatase inhibitor in doses of 5 milligram oral letrozole daily for these 60 days, it will have more effect and might give us better results. Third drug was Dynogest. I told you one was oral contraceptive compared with GnRH-agonist prolonged down regulation. Second one was letrozole with GnRH-agonist, and the other arm had GnRH-agonist alone. And all of them are comparing it with depot GnRH-agonist treatment, because that was what we grew up with since 2006 to this age, that it is only the depot preparations which can reduce the inflammatory effect of the endometriotic implants or the endometriosis in the pelvis. Now, this is pre-treatment with Dynogest in women with endometriosis undergoing IVF after a previous failed cycle. Highlights were IVF, we all understand, has worse outcomes in patients with endometriosis. The prolonged use of hormone drugs before IVF may improve pregnancy outcomes. Dynogest is a progestin with anti-inflammatory and anti-angiogenic activity. We heard this from Dr. Sonia Malik also, who sort of outlined this very well. Implantation rates may be higher as a result of receiving Dynogest before IVF. Clinical pregnancy rates may be higher as a result of receiving Dynogest before IVF. So implantation rates would get better and clinical pregnancy rates would get better in result. Oocyte quality may have no effect. What was the study like? This study was based on the retrospective analysis of a prospectively collected database, including 151 women who had failed a previous IVF cycle and all subsequent embryo transfers and had an imaging diagnosis of endometriosis. So they had one failed IVF cycle and maybe had 2 or 3 embryo transfers which resulted from that stimulation cycle, which all failed. Patients either underwent IVF without receiving hormonal treatment or received 3 months of treatment with Dynogest 2 milligram daily before IVF. The results was the largest diameter of endometriomas significantly decreased after DNG pre-treatment with a significant p-value. The use of DNG increased significantly the number of oocytes retrieved. Again, the p-value is significant. The fertilization rate by assessment of 2 pronuclear embryos and blastocyst formation rate in women with endometriomas of diameter equal to or more than 4 centimeters. So these were large endometriomas and they were given 3 months of continuous DNG. You read the whole study and you will know that when do they stop DNG, and they give generally a long protocol GnRH-agonist IVF controlled ovarian stimulation for LH suppression, and DNG is stopped at the time when the long protocol injection GnRH-agonist is started in the luteal phase of the previous cycle. This study suggests that in patients with endometriosis, IVF outcomes can be improved by pre-treatment with DNG. In particular, the use of DNG allows for better oocyte retrieval and blastocyst in patients with large endometriomas. The cumulative implantation, clinical pregnancy, and live birth rates were significantly higher in the DNG-treated group. So to revise, I would say that in endometriosis, we all understand the reserve is our concern, the approachability of the ovaries is our concern once, even if the diagnosis is established. GnRH-agonist depot preparations for 3 to 6 months had been recommended since last 15 years. However, now there is an emergence of oral drugs which can be used with or without GnRH-agonist, and the time frame is much shorter. 2 to 3 months causes the same effect which 3 to 6 months had caused with the earlier drug alone. And hence, either oral contraceptives on one side and GnRH-agonist on the other or letrozole with GnRH agonist, or dinogest on one side and GnRH agonist on the other. All three have benefits of giving us better number of oocytes, better pregnancy rates. Therefore, my take-home message from today's talk is controlled ovarian stimulation for IVF in women with endometriosis is similar to those without endometriosis. So do not think that endometriosis will have a different regime. The regimes are going to be same. If the reserve is low, you will have less number of oocytes. If the reserve is good or average, you will have average number of oocytes. The dose of gonadotropin and protocol depends on the age, ovarian reserve, and previous response to stimulation, as it is in all other cases. Attention is now focusing on pre-treatment in women with high-stage endometriosis to reduce the pro-inflammatory detrimental effect of the disease on oocyte, embryo, and endometrium. And if you remember your basics, in stage 1 and 2 of endometriosis, downregulation was never recommended. We just said, when IUI cycles were planned also, we just said stimulate the ovary and do IUI, but never downregulation was sort of recommended. So here also attention has to be focused on high stage of endometriosis to reduce the pro-inflammatory secretions effect of endometriosis, which is detrimental to oocyte and hence the embryo and the endometrium. And the first drug used for this purpose was prolonged GnRH agonist. However, a plethora of newer, cost-effective, and easy to administer drugs are being tried with the same aim of reducing proliferation, vascularization, and inflammation by endometriotic implants, thus its adverse effect on IVF outcome. One word before I conclude about adenomyomas. If the uterus is larger than 10-week size, the adenomyoma is diffuse or it is localized, probably GnRH agonist long-term for 6 months, 8 months, or 1 year may also be recommended till we can shrink the uterus to almost normal size or 8 weeks or 9-week size, and then doing a frozen embryo transfer may give us good results. Thank you very much for a patient hearing.